Now we move on onto our session on progressing with the treatment, and I'm delighted to call my co-chair to the first talk about the Asp-PSC trial. We have seen already PSC is one of the risk factors. We see how we can prevent this.
Thank you, Chiara. So I'm going to talk about this trial, and I'm presenting this on behalf of myself and Simon Rushbrook, who's my co-chief investigator for this proposed national study. So we are embarking on a trial called Asp-PSC, which is looking at the effect of aspirin on whether it reduces cancer and mortality in patients with primary sclerosing cholangitis, which is the commonest known predisposing cause for cholangiocarcinoma in the Western world. And this is predicated on the wise adage that prevention is better than cure. We've seen how cholangiocarcinoma can be such a difficult disease to deal with after diagnosis or even to diagnose. So is there a way to prevent people getting there in the first place? So just to recap a little bit about PSC, there may be some people sitting here who have PSC, but there'll be other people who don't know much about PSC. PSC is a chronic liver disease. We don't know what causes it. It's some sort of immune dysfunction in the bile ducts that leads to inflammation in the bile ducts, and that leads to progressive scarring or fibrosis in the bile ducts. That causes problems in bile flow, reflux of bile, damage to the liver, damage to the bile ducts. PSC may occur on its own, but most patients with PSC, around 70%, also have concomitant inflammatory bowel disease as well, usually ulcerative colitis that have a similar process going on in their colon. So most patients with PSC will have bile duct inflammation and colon inflammation as well. PSC occurs in both men and women. Classically, by the time it presents, patients are actually quite young, sometimes in their teens, 20s, 30s. And the problem with PSC is that patients are at high risk of cirrhosis and liver failure as a consequence. But if that's not enough, they're also at high risk of cancer, particularly cancers of the bile duct, cholangiocarcinoma, as well as colorectal cancer, if they have the colitis, as most of them do as well. If a patient with PSC develops liver failure, they can be transplanted. They can have a liver transplant, and that is essentially curative. But if they develop a cancer, aside from that novel indication, which is still not in place yet about transplant, and that's only a small minority of people, generally speaking, the development of cancer would be a contraindication to liver transplant. It would not be allowed to proceed. So it's a group of, if you're a hepatologist like me, PSC patients keep you up at night because you are just constantly worried that there's a risk of cancer. You almost wish upon them that they get liver failure because then at least you can transplant them. And I've never felt that about any other patient, wishing them liver failure. But in my PSC patients, I think if anything's going to happen, I want you to get liver failure so I can transplant you because I don't want you to get cancer, because then options can be potentially quite limited. So this is just a picture of PSC. You've seen pictures of the liver and the bile duct where you see nice-looking bile ducts. In PSC, you get this knobbly-looking bile duct. And a similar process can occur in the colon, ulcerative colitis, or Crohn's disease. So two forms of inflammatory bowel disease. Most patients have ulcerative colitis, which is in itself a high risk factor for colon cancer. And ulcerative colitis can affect part of the colon or the whole of the colon. So why do we need a study to see if we can reduce the risk of cancer in PSC? Well, as I've said, if they get cancer and then they get liver failure, they can't have a transplant. And the fact that they've got cirrhosis may well limit what treatments could be given for the cancer as well. And currently there are no proven treatments for PSC. There are drugs that we use, ursodeoxycholic acid, some new drugs coming out that might improve the liver test, but there is no proven treatment for PSC apart from transplant. There's no early proven treatment to reduce the risk of cirrhosis, liver failure, liver or bowel cancer in the future. So that's the big unmet need in this patient group. So some years ago, I think it was about 5-6 years ago, at this conference, actually, Simon and I, over a coffee break, said, because there'd been a lot of chatter about whether aspirin might reduce cancer, we said, I wonder if it might reduce the cancers that PSC gets. So Simon and I said, yeah, it's a good thought. Someone should look into this, right? A year later, we had another coffee and said, oh, there's been some papers out looking at this, right? And so a few years ago, a few papers came out looking at historical data. So this is what's called cohort data or historical data, where people look at patients on their books in their hospital who have a disease, and they look at matched people who didn't have the disease, and they look for differences, and they apply multivariate and other types of statistical analysis to see if there's a factor that seems to distinguish between the two groups. And there were several papers that had looked at the cancers that patients with PSC are at risk of, and looking and showing that historically people who've been on aspirin for some reason seem to have a reduced risk of cancer. So the Choi et al. Was the first paper of this from the Mayo Clinic, an odds ratio of 0.29 to 0.35. So their risk of cholangiocarcinoma was reduced by at least 65%. Another study showing a reduction in aspirin users for HCC. Then there was the 2 meta-analyses where multiple studies are combined and the data is combined to increase the numbers and increase the statistical power, which again hinted that there might be a reduced risk of cholangiocarcinoma in people who were taking aspirin for one reason or another. And then a study on Duke's stage A CRC, that's colorectal cancer, in people who are taking aspirin for some reason, right? So those papers 1 to 6 are what's called, I mean, this is not direct evidence, this is theoretical evidence. These sorts of studies are what we call hypothesis generating. They're not proof enough to warrant taking aspirin, because aspirin in itself is not without risk if you're taking it every day from a young age. There's risk of gastritis, bleeding, which people are at risk of anyway, risk of flares in the IBD. So it's not something that despite this historical data, one could truthfully advise people to take off the shelf. So what is required is a proper randomized control trial. In 2020, Byrne et al., a group from the UK, published a randomized control trial of aspirin, not in PSC, but in Lynch syndrome. Lynch syndrome is a condition where there's genetic mutations in several DNA repair pathways, which massively increase the risk of that person getting cancer. And they can get various types of cancer, particularly colorectal cancer. And they did a 5-year randomized controlled trial, and aspirin versus placebo, and showed that in aspirin use, hazard ratio, which means that the risk of getting colorectal cancer was 0.63, i.e. a 47% reduction as the headline figure. Now, Lynch syndrome is similar to PSC in that patients are young and they're at high risk of cancer, but the mechanism of the cancer is very different in Lynch syndrome compared to PSC. There's also some anecdotal evidence that after someone's had a diagnosis of biliary tract cancer confirmed, if they're taking aspirin for some other reason, then their overall survival may be improved. And again, that's cohort data, not scientifically proven, but an observational finding. So there was this epidemiological data, retrospective cohort data. There was this study from Byrne et al. Simon and I said, someone needs to do a trial in patients with PSC, but it's going to be very difficult. And then we had another meeting and said, well, maybe we should try and do it, right, and see if anyone would fund it. So the first question we asked was, well, is there any biological scientific plausibility on how aspirin might modulate carcinogenesis? Aspirin's been around for 100 years. It's cheap as chips. What does it do? How can it do it? And there is actually a lot of scientific data in the lab, in cell studies and animal studies about how aspirin might reduce cancer risk. So it inhibits COX-2, which has a role in inflammation and pro-cancer. It prevents platelet aggregation, inhibits NF-kappa B, modulates signaling pathways, upregulates genes that suppress tumors, and stabilizes proteins that repair damaged DNA. And there's lots and lots of data on this in the literature. So Simon and I, we proposed a trial where the hypothesis is that aspirin reduces PSC-related cancers, and the aim of the trial is to see if daily low-dose aspirin does what we hope it does and what the historical data hints at. So planning the trial, writing the grant took 4 years. We undertook multiple road trips presenting our idea and the trial idea to various august bodies, BSG, Basel, UK Cancer Prevention Team, NIHR, Cancer Research UK, MRC, seeing who might be interested if we undertook, because writing a grant application is months and months of work, and we didn't want to do it if right from the outset no one was interested in funding this trial. We spent a year writing the grant application, and then in September 2022 we got a letter saying that from Cancer Research UK saying they would fund this trial if we can deliver the patients. Right? The grant was activated in January 2023. It's and it's taken a year to set it up and get all the ethical approval, etc. And we are at the position now of starting to recruit. It's a 10-year study. It's going to take 5 years to recruit the patients. These are the colleagues and bodies that we have presented this research to leading up to the grant. This is the investigator team who are leading on this trial. And I've got a big shout out to our PPI group, our Patient Public Involvement Group. So Helen, who obviously you all know, Martine Wormsley, Chair of PSC Support. They had such an important role in writing the perspective of the patient and the public, advising us on the trial design. And honestly, I don't think we would have got the grant if it wasn't for their input. And Francesca is our overseeing senior statistician. So the trial design is investigator-led, so it's not a pharmaceutical protocol or a company protocol. It's led by Simon and myself. It's a phase 3 study. There's 2 arms to the study. The intervention arm is 75 milligrams of aspirin. The other arm, the comparator arm, is a placebo. It'll be double-blinded, so no one, the patient nor their doctors or nurses, are going to know who's taking what, because that's the only way to prove without a doubt whether it works. The target population, the study population who we need have to have a diagnosis of PSC and IBD, and they have to be at least 12 months post-diagnosis just to be sure that they don't have any cancer at the time of diagnosis. And 2 out of 3 participants will be given aspirin, and 1 out of 3 will be given placebo. So people who enter the trial have a 2 in 3 chance of getting aspirin. PSC is a relatively uncommon condition, less than 10,000 patients in the country. And we're going to need about 900 patients. So it's a lot of patients. No one has that many patients in one hospital, so we're going to need lots and lots of hospitals around the country recruiting patients to the trial. And so we said it would take 5 years to have all the patients, and every patient's going to need to be on it for 5 years. So we said the trial will take 11 years to complete, including a year setup. We're going to balance both arms for how much fibrosis or liver damage they have. The endpoints of the trial, so these are the outcomes we're looking to compare in the two arms. The most important one is cancer, any cancer, particularly the cancers that PSC patients are at high risk of. We also want to check whether there's any impact on listing for liver transplant and overall survival or all-cause mortality. And the secondary endpoints, we also want to accumulate data and look at the differences in the two arms in terms of risk of bleeding events, which is a risk with aspirin, liver decompensation, liver failure, and flares of inflammatory bowel disease, because we need to make sure that even if aspirin does reduce the cancer risk, it's not at the cost of other significant health concerns. So we need 774 patients to complete the trial. Assuming that 10 to 20% drop out for one reason or another, or change their mind, we estimate we need to recruit over 900 patients to safely deliver the trial. This is it's a big ask, so we're talking about 1 in 7 of all PSC patients, maybe 1 in 5 of all who are eligible. So when I initially saw that number of you're going to need 900 plus patients, I have to say my first thought was not deliverable. You need so many patients, such a rare condition, we won't be able to do it. But patients with PSC are a very switched on, savvy, keen, highly educated in their disease group. Over almost 3,000 have voluntarily donated their samples, biosamples, to UK PSC for research purposes. So if there's any group of patients that you can recruit to, it's this group. The whole trial includes, and it's not that Simon and I were given millions right at the start. It's the money will be released year on year if we can show recruitment. So that's going to be the challenge. Here's the inclusion and exclusion criteria. So they've got to have PSC and IBD, at least 18 years old, no previous cancer, not already on aspirin, and at least 12 months post-diagnosis. And obviously able to give informed consent. PPIE group, again, just to say again how important they were, Martine and Helen particularly. They have extensive experience of PSC and cholangiocarcinoma respectively, of course, as you know, been heavily involved in previous publications and guidelines. As part of the trial, as part of the grant proposal, so when you write a grant like this, your chance of success is about 10%, and you're competing with very eminent professors applying for grants for the same pot of money for leukemia or brain cancer or other conditions, prostate cancer, right? All of which are obviously very, very important things. So the chance of success is about 10%. As part of the grant, so your grant proposal it's got to be really tight. It's got to be really, really tight. And one of the things that really made it tight was this questionnaire that PSC Support did on a survey of almost 200 PSC patients around the country, of which to ask them some various questions. 3 main ones were, do you believe it's extremely important to reduce cancer risk in PSC? 90% said yes. I'm not sure why 10% didn't say yes, I have to say. Would you be interested in taking part in a 5-year study? And 86% said yes. And the key question is, are you already taking aspirin regularly for some other reason? And 87% said no, and I think this was a key bit in the grant proposal. And Martine and Helen have been really crucial to advising us about the randomization ratio, recruitment strategy, etc. So that's just a flow diagram of the study. We're also proposing that the patients will be seen every 6 months by the trial team at their local centre, as well as their NHS follow-up, which will happen as normal. We also aim to collect serum and urine samples so that we could establish a unique UK bioresource for years to come, and that bioresource would be potentially 900 patients with 6 monthly samples over 5 years, some of whom get cancer, some of whom don't, some of whom get cirrhosis, some of whom don't. And that would be open to all investigators and researchers developing novel biomarkers. And that would be, even if the trial isn't successful, that itself would be a great legacy to leave for the next generation of cancer researchers. So it was costed for, and we were awarded over 5 million, but pending recruitment. So we're starting recruiting now. We've opened our first sites. So for those of you sitting here who have PSC or have PSC patients, please start thinking about patients now. And that's a summary slide, which I'll leave there just for a few seconds. Thank you very much.